Hello, my name is Gary Zammit, and I am the President and CEO of Clinilabs Drug Development Corporation. I'm pleased to be with you today to introduce you to my friend and colleague, Dr. Yves Dauvilliers from Montpellier, France, where he is the director of the sleep clinic there. Montpellier is the oldest university of medicine in the world. So he's coming to you from a prestigious institution to talk to us about narcolepsy. Hi, Yves. Thanks for doing this.
Thanks, Gary. Happy to be with you today.
So let's talk about narcolepsy, and I'm going to ask you some well-worn questions, but let's start with, what is narcolepsy? How is it defined?
Yes, so narcolepsy is known for, more than one century, defined by a French guy, Jean-Baptiste Gélineau, and also Westphal in Germany. It was clinically defined at that time with sleepiness and cataplexy. And after there is some classification with the discovery of REM sleep, and there's a lot of REM sleep during the naps, as we can assess with the multiple sleep latency test. And more, there is some differences with patients with narcolepsy with and without cataplexy. At the beginning, it was not defined as two different entities. Right now, it was two different entities, completely different because of a lack of a peptide. We will certainly discuss that more in details with orexin, also named hypocretin. And in narcolepsy type 1, it's now defined like that, like for diabetes, type 1, type 2, for exactly the same. If you do not have the peptide in your brain, namely, again, orexin or hypocretin, you are affected with narcolepsy type 1. If it's normal, or at least not deficient, because there is a gray zone, as always in medicine, it's narcolepsy type 2. So it's not exactly the same as narcolepsy with cataplexy type 1 and narcolepsy without cataplexy type 2, because one is clinically defined by the presence of the cataplexy, and the other is defined by the presence or absence of the peptide. And it's not exactly the same, but we will come back on that soon, for certainly.
Okay. So can you describe the symptoms of narcolepsy, particularly cataplexy, which you've mentioned?
So cataplexy is very key, important symptoms. We need to spend a lot of time on these symptoms because it's pathognomonic. What is pathognomonic is you do see cataplexy just in narcolepsy. Sleepiness, we will discuss on that a bit after. It's very frequent in general population. But cataplexy, if you are certain that cataplexy exists, it's narcolepsy. And it's a loss of muscle tone triggered by strong emotion, mostly nice emotion, laughing, rarely stress, rarely anxiety, is mostly a nice emotion. And you will, as a trigger, as a reflex, in a second or even less, you will have a loss of muscle tone, mostly localized on the face, on the knees, on the neck, and sometimes this is partial cataplexy, so partial loss of muscle tone. And sometimes, but less frequent, probably 10% only, is generalized, is you will fall down, it's complete loss of muscle tone. The duration is mostly few seconds. It could be 1 minute or so if the trigger persists, if you continue to laugh. But if it's just a short trigger, mostly it's few seconds. And is bilateral, there is no unilateral cataplexy, and you are completely conscious. There is no lack of consciousness. You are not asleep. And so you need to differentiate what is falling asleep and what is cataplexy. Cataplexy, you are fully awake. There is a little bit specificity in kids, in children with narcolepsy. Sometimes they move. There is not a clearly loss of muscle tone. Sometimes there is some movement, stereotypic hyperkinetic movement, but it's mostly close to disease onset and that disappear time to time.
When we talk about narcolepsy with cataplexy, as you said, that's type 1 narcolepsy. What about other symptoms that might be associated with the sleepiness and cataplexy? What else goes along with it?
We discussed about cataplexy, but the first symptom that really is the motivation to go to see a sleep doctor is sleepiness, the daytime sleepiness. And that is key as well, because a lot of people I do see in routine are very sleepy, but they are not narcoleptic because narcolepsy is a rare disease. They are sleep deprived, they are depressed, they are with shift work, they take drugs, they are with ADHD, with obesity, with OSAS. So there is a lot of associated factor. But in narcolepsy, it's very short naps. They have 5 minutes, 10 minutes, 15 minutes, and mostly they dream during the naps. And after having 10 minutes of naps, they are refreshed. And in between two naps, they are okay, completely okay. It's not like in idiopathic hypersomnia or they are drowsy all day long. In narcolepsy, it's short, refreshing naps with dreaming content. And the naps or sleep attacks, when it's very abrupt and you cannot resist, is 2 to 5 times a day. So this is sleepiness. After there is the cataplexy. When you fall asleep with dream content, sometimes there's hallucination. So the dream content, so the REM sleep start, but you are not completely asleep. So you are aware that this hallucination is coming in your wake before you are fully asleep. That's sometimes problematic, and sometimes there's some anxiety related to the type of hallucination you may have. Could be visual, could be auditive, could be synesthetic, and associated with the hallucination is sometimes sleep paralysis. So you cannot move. So it's terrific because you have hallucination and you cannot move. And if you want to move because you have, depending on your dream, you obliged to move because of some violence in your dream, and you cannot move. That could be an issue. And when is hypnagogic hallucination, namely is when you fall asleep, that is often typical of narcolepsy. One is when you wake up, is like hypnopompic hallucination at the end of a nap or at the end of a nighttime sleep. This is quite frequent in general population as well, and mostly with anxiety, depression. And the last symptoms, very often problematic, even more than hallucination and sleep paralysis, is disturbed nighttime sleep. The patient complain a lot of awakening at night. It's not insomnia. They have not problem to fall asleep by definition because they are very sleepy guy. But after a while, after 1 hour, 2 hours, they wake up completely refreshed, and they need sometime half an hour or 1 hour to go back to sleep. And that may exist 3-4 times at night. So if you wake up 20 minutes 4 times at night, that's an issue. But it's not really insomnia. They have not problem to fall asleep. They are fully awake, in between. So this is what we call the PANTAB, excessive daytime sleepiness, cataplexy, hallucination, sleep paralysis, and disturbed nighttime sleep. And in addition to that, you can see a lot of other symptoms, but they are not specific at all. But obesity, depression, anxiety, precocious puberty, but that exists in many other different conditions. So it's not specific at all.
I was just going to ask you about some of those other symptoms, like disturbances in social or occupational functioning, the mood disturbance that patients sometimes report, and weight gain. Weight gain seems to be part of narcolepsy, isn't it?
Yes. So as I said, there's a lot of other symptoms that may be associated in narcolepsy, and for all of the other, it's very hard to dissect if it's really related to orexin deficiency, as an example, or is it related to the consequences of having a chronic disease. And so mood disorder, as an example, it's problematic to fall asleep all day long during meeting, and your career or university level will not be as expected because you cannot success in the good term. And there is some stigma also related to the cataplexy. When you are with loss of muscle tone, everybody can laugh at you. So there is a lot of stigma on that. Obesity is different story because mostly it's half of cases, so it's huge, but it's mostly close to disease onset. So this is key. When you diagnose a patient with obesity and sleepiness, everybody will think first about OSAS, or obstructive sleep apnea syndrome. But if it starts, at 20, in the same time of sleepiness is not always mostly. You need to think about narcolepsy. So depressive symptom, yes. Obesity, for sure. Anxiety, depression, precursors puberty, but this is very particular. You need to be very young kids below 9 years old. And the quality of wakefulness is also an issue because you can be in between. Sometimes you are falling asleep, sometimes you are awake, but sometimes you are in between, and there is some automatic behavior. It's very frequent in children with narcolepsy. They continue to draw, to write something in textbook, and at the end they cannot. They are not aware that they do so, and when they wake up, it's not waking up because they were not asleep, but they are in between zone, in gray zone on the. And sometimes they did not recognize that there is amnesia of this in between state. So the quality of wakefulness is really something of interest.
Yeah, that sounds like a very interesting aspect of narcolepsy, and I hadn't given it much thought, but I think I've experienced almost something like that when I'm overtired after I've worked a long, long day and I'm at my desk or at my computer and I have work that is yet to be done. I want to work, but I can't seem to organize myself around doing it. And then I know I have to excuse myself. I have to stop and rest. But it boils down to that quality of wakefulness. All wakefulness is not the same.
Now you're fully right. And when you are in this state, you know that is because of sleep deprived, because of shift, because you take the plane and there is some jet lag. So you understand the reason why. When you are affected with idiopathic hypersomnia, it's different story. We can have another call on that next time. It's all day long, They cannot really change this state. They are always in between, in drowsiness. For narcolepsy, mostly they are okay, and when they are in this state is because they fight against sleepiness. And after a nap, they are okay. So it's in between, but sometimes when you are at school, you don't want to sleep because it's stigmatization again and again. So you fight against that and you are in this shape. But you can recover if you take a nap. In idiopathic hypersomnia, they don't want to take nap because it will take 2 hours, 3 hours. And when they wake up, they are in the same shape. So why they need to do so? They need to behave differently.
Mm-hmm. Now, is it fair to say that narcolepsy type 2 is essentially the same as narcolepsy type 1, with the exception of the cataplexy? Are the symptom pictures pretty much the same, or do they differ in other ways?
Yes, that's an excellent point. Narcolepsy type 1, it's clear. It will be chronic, it will be stable, mostly. With age, you can adapt your cataplexy because you know how to manage your trigger. And with age, you have bad sleep at night because of aging, but not really because of narcolepsy. But mostly it's a stable disease. It's a disease, autoimmune disease, that will target the orexin neuron that will disappear because of these autoimmune attacks. In narcolepsy type 2, I may say all the time that is not a disease, it's a disorder. And the meaning of that is subtle differences could be, but there is change that make you sleepy and with high propensity to fall asleep in REM sleep, in the dreaming naps. But you can recover. 50% of cases, in my experience and other experience worldwide, show that after a while, 5 years, 10 years, when you reassess the patient, they are no more affected with narcolepsy type 2, half of cases. So it's not 1%, but it's nice to say so that you can recover. It's a nice hope at the end. Second is why. Why is going wrong in the brain? To explain that is highly heterogeneous. It could be sleep deprived, it could be shift work, it could be anxiety, depression, CNS drug, antidepressant intake, OSAS sometime, and a mixed bag. Mostly is a mixed bag of sleep deprived, obesity, depression, and drug intake. And that leads to this sleepiness with high propensity to dream in your naps. And to say so for sure there is no cataplexy. The sleepiness is mostly less severe. And we did publish a paper to assess all of these symptoms with validated scale. The narcolepsy severity scale we developed in my lab 10 years ago for narcolepsy type 1. But we validated that in narcolepsy type 2. So except the 3 items on cataplexy for sure, because they are not affected with, but we can quantify hallucination, sleep paralysis, and bad sleep at night, and also sleepiness, and they are less severe. They are in between. I may say that sometimes half of cases who do have sleep paralysis in NT2 is 1/3. So, it's less frequent and less intense symptoms, because the problem is not yes or no, is what about the frequency of the symptoms, the duration of the symptoms, and the consequences of having these symptoms on your daily life.
Okay. Now, what causes narcolepsy?
So NT1, we do know more and more that these neurons is 80,000 neurons. We have 1 billion neurons in the brain, and only 80,000 localized in hypothalamus, the lateral dorsal portion of the hypothalamus, with these neurons who cannot continue to synthesize and to secrete this orexin or the name hypocretin. So it's very focused on, but there is a huge distribution of the receptor of this hypocretin over the brain, over the whole brain. So it's nice to say that it's very focused on, but at the end is project on very key target over the whole brain with 2 types of receptor 1, receptor 2, with different function, and it's of interest because we are lucky to have drugs right now who binds this kind of receptor. And why it's no more efficient, this orexin neurons, is because of its autoimmune process. The well-known autoimmune process is diabetes, is lupus, is multiple sclerosis. And here the target is certainly the narcolepsy, the orexin neuron, and your lymphocyte, the CD8 T cells. I don't want to go too much in details, but will recognize this part of your neurons, as on the membrane of your neurons, and will destroy them. So it's not antibodies, it's not B cells, it's T cells. And more data on that are very reliable data, and with genetic background. And HLA, as an example, is HLA DQB10602 is a allele that predisposes you to be narcoleptic. There is the environment with, we know some virus, the flu virus, the pandemics, the vaccine. So it's a combination of the predisposition, genetic background, some key environmental factor, and will destroy your orexin neurons, and you will be in trouble for the rest of your life. For NT2, as I told you already, it's very heterogeneous. The genetic is not there. Orexin are preserved. So it's a mixed bag of, you may have a little less orexin, same genetic predisposition or not. It's very heterogeneous.
And if we let's just think about narcolepsy type 1 for a moment, is there a reason that symptoms begin to appear when people are in their late teens or early adulthood? It seems like it lays dormant for a while. Or is that just a matter of detection? We don't pick up symptoms in younger people.
So we did this study many years ago showing that the age at onset in narcolepsy type 1, we ask for age at onset of sleepiness and cataplexy or both, and mostly it starts around 15 years old. So there's 2 peaks. One is 15 years old, so the peak is between 12 and 20. It's 80% of cases, and there is a second lower peak, 20% of cases around 35 years old. So it's a kid's disorder. But that's key point. We are not very good worldwide, again, because it's rare disease. And nowadays, in Europe, in US, the delay to be diagnosed is around 6-8 years. So most of patients I do see are 20, 22, 25. And when you ask deeply, when did you fall asleep the first time? Is it at school, at university? And mostly they say they start around 14, 15, 16 years old. Sometimes we do diagnose patients below 8, below 10 years old. The youngest patient I did diagnose myself is 3 years old, but it's very, very rare. And for that, you need video to see the cataplexy, because when they are sleepy, it's reckoned to be sleepy at that age range. So it's mostly because of the cataplexy. And we can be sure of the diagnosis because we do the orexin measurement. I know that in US, a few people do that, but it's very easy to do. It's 2 minutes, even less, to do a lumbar puncture tap. And after you have the answer, like for diabetes, diabetes, you measure the glucose. Okay, it's in the blood. It's easier for sure. But it's nice to prove the orexin deficiency and the severity of this deficiency, because sometimes you cannot even detect orexin, and sometimes they are in between, and it's of interest for lifetime, and also because of drugs that will be on the market in a couple of years. But we are, as you know, working on the binding of orexin receptor to receptor, and it's nice to see how many orexin are still there.
Let's talk about the current standard of care. And, as you're saying, there are new drugs in development, but what do patients have access to now, today? And what might these current development programs bring to them in terms of a different type of care?
So it's a complex question, and I may answer that in different ways. First, we are lucky compared to other sleep disorder, because we do have a pipeline with several drugs. On sleepiness first, there is amphetamine and a derivative of amphetamine with methylphenidate that start from the past, but they still work correctly, but with a lot of safety issue, but it's not very costly, so sometimes they start with this kind of drugs. Yeah, I may say that it's not good for the benefit-risk ratio, but it's good for the benefit only. After, there's the modafinil and the related armodafinil, and we do see that it works. We know that from decades. It's all compounds already. And after, we do have the pitolisant, the solriamfetol, and these drugs are very helpful to fight against sleepiness. So we did some guidelines how to manage not narcolepsy, but symptoms-driven narcolepsy. What is really an issue for a patient? It's not because cataplexy are present that you need to treat cataplexy. For sleepiness, you need to treat to avoid car crash accident, as an example. And for sleepiness, you have pitolisant, modafinil, solriamfetol as a first line. And when it's not enough effective, you can switch on or combine with these drugs or with other drugs I will refer on. For the cataplexy, there is just 2 drugs. Well, I may say 3 drugs. The first is oxybate with different drugs. Is once nightly with sodium, without sodium. So I don't want to put the name, but you know the name. And it works almost in the same way, but with different characteristics for the pharmacokinetics or the salt intake. And it is a very, very effective drug for cataplexy. And also for disturbed nighttime sleep, but I will come back to that in a minute. The second to treat cataplexy is pitolisant, with nice recent data on cataplexy. It's probably less potent than oxybate for cataplexy, but with some efficacy reported in literature. And the third, but off-label, but it works, is all SSRI, SNRI, so-called antidepressant, but it's off-label. But we do know one example is the venlafaxine, very often prescribed by experts in the field, but again is off-label. So one is sleepiness. There is 3 drugs: modafinil, pitolisant, solriamfetol. One is sleepiness plus cataplexy to be treated, not just as a symptoms, is oxybate and pitolisant. And when you have sleepiness, cataplexy, and disturbed nighttime sleep, there is just one drug, oxybate, because it works on disturbed nighttime sleep very well, and no of the other drugs may work on. So I missed the point on purpose, is that oxybate may work also on sleepiness, but probably is not the first step if there is no all of the other symptoms as a first line. I discussed about the first line. After second line, you can combine, switch, and add on. And after, you need to take care also about other comorbidity or endophenotype. So depression, obesity, sleep disorder breathing, parasomnia, and that may guide you, because I propose different drugs, but after there is this safety issue or this blood pressure as an example, and cardiovascular problem, depression, obesity, and sometimes drugs may help you, or in contrast may even aggravate that. So that need to be, I think we are lucky. I said that I didn't discuss about mechanism of action, but I just listed the name of the drugs, but we can discuss just after on mechanism of action. But what I love to say is we are lucky to have a lot of drugs. So the objective right now is to go to precision medicine. Is not narcolepsy need to be treated by that, is which kind of patient phenotype are you to propose this kind of drugs.
Okay, and what's new in development?
Yes, so a lot of new in development. I may say recently there is this once nightly oxybate. There is also the pitolisant in children with nice data. Oxybate in children is came from a few years ago already. So and solriamfetol also for kids. There's ongoing studies on that. So I think all of these drugs I already refer on are with still some evolution to go to different phenotype, different age group, and so on. I'm aware also about reboxetine with some recent data with press release, and pitolisant in idiopathic hypersomnia with also some press release, but nothing is published. So I want to be not so much engaged in that, but it's of interest to know that the field is evolving. But the most exciting recent development, I may say in a couple of years, is orexin story. Why? Because we do know that orexin deficient in narcolepsy is 24 years ago. In 2000, it has been reported by my friend Emmanuel Mignot in Stanford. So in 2000, with brain collected and a CSF collected, and 24 years ago, there is no drugs with orexin on the market. But since the last couple of years, we are lucky to have drugs that may bind orexin 2 receptor. So it's not exactly orexin, is because it cannot cross the blood-brain barrier and will not really go with enough level in your brain. But we have some agonists that may bind some of the receptor with not too much safety concern and with very good efficacy. So it's really what we want, not just to give drugs that help the patient to cope with on daily life with symptoms. That's nice because we are very helpful for the patient. I say all the time that 80% of my patients are improved by 80%. So there's a room still, but we can do a lot. But when you are able to manage patient in trials nowadays, but we do have open label, so we can continue to use the drug. So we are with quite good knowledge already, even if there is nothing on the market. But these drugs are lovely because of mechanism of action and because of efficacy. And really, it's key to believe that it's not just to treat symptoms. I love to treat symptoms to help my patient, but when you treat the disease, it's a different story. And if you treat the disease, you will treat the symptom by definition, but is to treat what is missing in the brain for the patient. So, and as a consequence, symptoms will disappear. But first, to go deeply is what's going wrong in my brain and what I can give you to reverse the problem is lovely.
So the newer treatments really have the potential for disease modification, not simply symptom relief or symptom treatment.
Yes, that's the point. Disease modification, this is a big world because you need to continue to take the drugs on a daily basis. So it's not really that you take a drug and after everything is going well. But like insulin for diabetes, they need to take that on a daily basis, but they are very happy to take it because if not, they will die. So for narcolepsy, it's lovely to see that after a while, the symptoms did not going back and they are very well managed with drugs. So the first drug we published 2 years ago in New England Journal of Medicine was very, very effective with some safety issue. But the new one we are working on, there is no safety issue, no hepatotoxicity, and a nice efficacy. But again, it's not published like the other drugs I refer on. So let's wait for a formal assessment with peer review to be sure that the benefits ratio will be good. But I may say that based on what I do know, it's highly promising. I don't just want to say so. There's a lot of companies who work on it. So in a couple of years, yes, we will be lucky to have this drug on site for patient. But nowadays is just promising, no more than that.
Okay. And some of the people who might be listening or watching this conversation might be considering participation in a clinical trial. And I know when I've talked with people about participation, they've said, well, I'm reluctant to discontinue my current medication, or it's a big time commitment. What could you tell people who are thinking about participation? What are some of the aspects of participation that they should think about?
Yes, that's excellent point. And you need to spend a lot of time with the patient to explain the design and the problem. Because if you say, yeah, stop the compounds and you will take the new one and you will be happy, it's not correct. It's not correct because the key problem, as you just say, Gary, is to stop the drugs. And especially when you stop venlafaxine, is a nightmare. You have a big rebound of cataplexy. When you stop Xyrem, the oxybate, as a rule, could be Xywave or Lumryz, you will have less rebound as the first day or the first few days, but after a week or 2 weeks, depending on the dose, you will have a big, not as a rebound, but a big, the symptoms will reappear for sure. So that's a real issue. You need, as a function of the dose, when you go into this trial, to stop for probably 1 month, to have stable dose for 2 weeks, because during the first 2 weeks you will be unstable with some rebound sometime depending on the dose, and after 2 weeks you will be stable with still your severe narcolepsy symptoms, and after you go to the trial. So yes, for during 2 weeks, 4 weeks is really a problem. But after you go to the trial, and this is less a problem, because you may be managed with the placebo, but you never know, and you will see the doctor very often, and sometimes you are not happy, but it could be related to the dose. So you increase the dose, you wait 2 weeks, you will see the doctor again. So you are, in good management. And if you have problem, you can discuss, interact. So for me, the placebo is not the big concern because mostly it's 2 months. So it's quite short trial, the randomized control trial. The problem is before to stop the drugs. To be on drugs during the trial is less an issue. And after 2 months, why we are highly motivated is because of the current trials on orexin receptor agonist, because it's safe right now, you can continue the drugs. So if you are, during 2 months without the correct drugs or the not correct dose for you, after 2 months, you can be treated on an open label and you continue the drugs. And I have a 17 patient right now myself who is ongoing trial. So it's highly motivated because you say you do an effort for 2 months, but after, regardless of in which arm you will be, you will get the drugs. So it's, if it's just 2 months to do an effort, but after it's done and many thanks to participate, no, it's not nice. But right now we can say you will be able to continue the drugs.
Yeah, so the pharmaceutical companies are designing studies so that patients, when they first participate, they might not get the active drug, or they might, but no matter what, at the end of that 2-month period or so, then they go into open label where they're all going to have access to the active drug. So even if you were on placebo first, you can get the active drug afterwards. Is that correct?
Exactly. You sum up exactly what I wanted to say. And currently, we have 5 arms. Is what I say is not a big issue to be with the placebo, because nowadays is 20% chance of having the placebo, because each arm, you have different dose, different combination of dose, if it's during the morning or at lunchtime. So sometimes it's the same dose, but twice a day, sometimes it's just once a day. So you have a lot of possibility. So you never know, you are not in good shape. Okay, is it related to placebo, the dose, or BID versus QD, so once a day or twice a day? So you don't know, and you're waiting for. Sometimes it takes a while to be better. Depending if you want to treat sleepiness or cataplexy or disturbed nighttime sleep or the stress symptoms. But at the end of the randomized control trial, yes, you can be treated with the good drugs, good dose for you. So I think it's highly promising.
That's great. Is there anything else that you would want the audience to know about narcolepsy? Anything else that's important?
Yes, last point we may discuss is the dose, because the press release of the orexin agonist I just refer on show that it works on narcolepsy type 1. Again, highly promising, and I don't want to again make too much emphasize. Let's wait for the complete results to be sure that everything is under control. But what we do know is for narcolepsy type 2 with orexin normal level, or at least not orexin deficient, you can be again in between level, the dose request to be effective is higher. Yeah, and that's of interest to emphasize that, because you can expect the opposite. When you do not have orexin, you need a lot, like for insulin, and when you are with in between level, you need little dose. And for narcolepsy is exactly the opposite, and probably is related to the receptor, the number of receptors in the brain, what we so-called hypersensitivation of the receptor. Because if you do not have the ligand, the orexin, for a while, your receptor are hypersensitive. If you have still some orexin in your brain, your receptor will be less effective. So to treat narcolepsy type 2 and tomorrow idiopathic hypersomnia, and tomorrow again all sleepiness related with normal orexin level, you will need high dose. And if you need high dose, the safety issue is not the same. So it's not the same compound. So all of what I did say for the highly promising is nowadays for narcolepsy type 1. But for tomorrow, for the other sleepiness in OSAS, in IH, in NT2, in depression, probably it may work, but who knows currently.
Fascinating. Well, this has been a fascinating conversation. I could listen all day. I'm learning things myself as a sleep specialist. I'm learning things myself listening to you. So I would love to continue the conversation, perhaps in another session. But thank you so much for talking with us today and sharing your expertise.
Thanks, Gary. And I was very pleased to have this conversation with you. And we can discuss next time about idiopathic hypersomnia, which is really a less known disorder and of key interest as well, with long sleep. And sometimes patient can sleep 12, 15 hours a day, and a lot of stigma as well. And we can spend time to discuss on that next time.
I would love to. Thank you again, Yves.
Bye-bye.
Bye-bye.